So now that we've learned about how cool dysrhythmias are, now we need to know how are we going to treat them. So as always, we're going to learn more medications, your favorite. So how do we treat dysrhythmias? So we can use drugs and devices or procedures to treat them. So there's lots of different drugs that we can use to treat these dysrhythmias, and I'm going to bring up what is common and you're going to be seen done in practice in the big guns. There's a lot in your book, but I'm going to try to narrow down to some of the ones that you're going to see most often used. When we're talking about drugs, there's a couple different things that these dysrhythmia drugs can help with. Some dysrhythmia drugs can help to convert them, which means it's going to get me back to normal because that's my goal, of course. At the end of the day, I want a normal rhythm. Um, so some drugs convert them, and the ones that convert them also help to slow them down. So I'm talking about amiodarone, calcium channel blockers, digoxin, adenosine. All of these help to convert and slow down rhythms. Some medications like beta blockers, they can't convert you, but they can at least slow you down. If you have a really fast rate, that can be helpful. Because at the end of the day, if I can't convert you back to a normal rhythm, if nothing else, I want to keep your rate between that 60 to 100 so that, we can keep the best possible cardiac output. Because if you remember, we don't want the heart moving too slow and we don't want it moving too fast. We also have medications that can speed them up. Sometimes, like when we're talking about bradycardia and things like that, we need to go faster because we're not going fast enough to get adequate cardiac output, or we're not going fast enough to in like a heart block or something like that. So for those, we can use dopamine or atropine. And dopamine's a continuous infusion, and atropine is, like a push medication. But both of these can be used. We're going to go kind of a little bit more in depth into each of these medications here on the next slides. There's also devices or procedures. So we can also speed them up, like with bradycardia or heart block with a pacemaker. And there's, a couple different types, and we're going to talk about those. Or we can convert them. They could have cardiac surgery, fixing the cause, or they can even go to the cath lab and have procedures done like ablations to try to convert them into a normal rhythm. Then we also have defibrillation or cardioversion, which is literally trying to shock you back into the rhythm the normal rhythm that you need to be in to have good perfusion. So let's start with drugs that convert or slow down. There's amiodarone, and you're going to see amiodarone used for a lot of different possible dysrhythmias. So atrial fibrillation, atrial flutter is one of the most common medications used, as well as VTAC. Whether or not there's a pulse in VTAC, amiodarone can be used. It's used for VTAC with a pulse. It's used for VTAC without a pulse. And then it's also used for ventricular fibrillation, like in a code situation. I always remember amio will make it slow. There's also adenosine, which is used for SVT and PSVT. And I remember adenosine because it discontinues the electrical node. So if you remember this one, this is the one I talked about that actually turns the heart on and turns the heart off and turns it back on. So in other words, it pretty much stops the heart and then it restarts it in hopes that when it restarts that it will be back to normal. There's also cardizem, which is a calcium channel blocker. And this is used for atrial fibrillation and atrial flutter. It can be used for some others as well, but most commonly that's what you're going to see it used for. And it's given as you give it as an IV bolus. Most of these medications you're going to see when patients are in these rhythms, they're not going to be PO. These are all IV medications because when it comes to dysrhythmias, we're not messing around. We got to get something happening to the heart quick. And then there's also digoxin, which we learned about, when you learned about heart failure, you learn about it. But this digoxin is also used for atrial fibrillation and flutter. I haven't seen it used in a lot of other rhythms, and it's not our first choice because it's a toxin, like it says there. But keep in mind, at the last, kind of last resort, we do go to digoxin. But of course, you just need to always keep in mind, that normal, range of 0.5 to 2, and that we need to look for signs of toxicity and monitor their potassium levels and things like that, because that toxicity can cause more abnormal rhythms. You fix one rhythm and then you create another. So we definitely need to keep an eye on that. So there's also drugs that slow down or speed things up. So we can slow it down. And we talked about with beta blockers. Like beta blockers, they don't have any ability to convert you out of an abnormal rhythm, but they can get you down to a normal rate. And so going back to that cardiac output, if my heart is really, really, really going fast, then the problem there is that I don't have time to fill. So at least even if I have kind of a chaotic like atrial fibrillation where it's just randomly fibrillating on the top of the heart, and that's maybe not great for my cardiac output. At least if my rate is 60 to 100, I have a better chance of better cardiac output because I'm, beating at a normal rate. I'm not beating so fast. I still have time to fill. And so that's the goal, with beta blockers, is at least to slow it down where you have time for filling. There's also medications that can speed it up. So there's atropine, which is an IV push medication. And this is used for bradycardia. Atropine is really just a band-aid. It's not going to help long term. If a patient, if they're bradycardic for some reason, what I mean is that we always need to get to the point of why are they bradycardic? Why is their heart rate low if it's a problem? Because atropine's not going to work long term. Kind of think of it like giving D50 or glucagon to a diabetic. Like that sugar is going to help for a while, but if there's something that's driving their blood sugar low, like we need something else to get it up. And same with atropine, it's just a band aid. Um, and I always remember atropine because it triples the rate of the pulse. So it does, and it. I don't mean literally like that. It sits there and it literally makes it triple. But what I mean is it increases the pulse. There's also dopamine, which I mentioned was a continuous infusion, and that's used in bradycardia and heart block. And I remember dopamine because it's a pulse accelerating machine, PAM. So the overall takeaways, and of course I've got some mnemonic and rhymes for you. I know you love those. If you need to speed up the heart, atropine, dopamine, and pacing is where to start. If you need to slow it down, beta blockers should come around. Amio, and DIDGE will help you to convert and get you out of your irregular spurt. So much fun. And then adenosine will restart the heart fresh and clean. That's the hope, at least, right? So there's also pacemakers. So I mentioned devices. So pacemakers speed things up. Now there are sometimes that pacemakers are used to slow things down or get things more regular, but keep in mind, generally 9 times out of 10, pacemakers are used to speed things up. So for slow rhythms, they have a set rate. So in other words, like I think about what's a normal heart rate, 60 to 100. So most of the time, pacemakers are set at 80. So I want this patient's heart to beat at least 80 beats per minute. Pacemakers can be temporary, which means I can literally like attach those pads like I do for to do defibrillation, and they can shock you, but ouch, it's literally shocking your skin. That's really painful. So we don't do that to people that are wide awake or don't have some sort of sedative or something, because that's just really mean. But we also can put a pacemaker in through your blood vessels into your heart. What do you call it? It's called a transvenous pacemaker. And then, of course, we can also get a permanent pacemaker, which is inserted usually in your left upper chest. And that can help to pace you over time. We can also insert things that can, what is called a ICD, which is an implantable cardioverter defibrillator. And that is, for patients that have a high chance of going, they've already been in VTAC before or VFib, and they have a high chance of going back into it, like patients with cardiomyopathy or that have really bad heart disease or heart failure. A lot of times people end up with that because then when they're at home, if they go into that rhythm, their pacemaker can actually sense that and then it can actually shock them too. So that way that it prevents them from sudden cardiac death. And they even have a dual chamber pacemaker. It's called a biventricular pacemaker for heart failure, which is pretty cool. That it literally has a pacemaker on, it has like a lead on both sides of the heart, and it helps to keep the heart in sync because one of the problems in heart failure is that it gets all out of sync. But as a whole, what I really want you to think about when you think of pacemakers is it's just going to help keep you at a set rate. And you can see how this is the EKG or ECG of a patient that has a pacemaker. And so you can have a pacemaker up in the top of your heart. So you can see these people, they have a little, kind of this little splotch or line before their P wave, because remember, P wave is the top of the heart. And so this is telling me that the top of my heart is being paced. So it's forcing the top of my heart to beat so many beats per minute. We can also have a pacemaker just for the bottom of the heart. And so in this lower left-hand corner, this is a picture of a ventricular pacemaker. And so you can see when I am, you see that wide and ugly looking QRS, and that's because this is not this person's heartbeat. This is a pacemaker forcing this patient's heart to beat. So it's always going to be wide when they have a pacemaker. And then last but not least, you can actually pace both. You can have a pacemaker for the top of the heart and the bottom of the heart. And so this is what they call an AV or atrial and ventricular pacemaker, or AV pacemaker. And so you can see there's a little line before the P wave and the QRS, which is showing both the top of the heart and the bottom of the heart are being paced. Now, you don't need to know that too much in depth, and I promise we're not going to show you a picture of one of these and say, well, is the top of the heart being paced, the bottom of the heart? I can't speak for complex. I can only speak for adult. But, at the end of the day, that's not necessarily what's important. What we need to know is making sure that this is working. So if I have a bunch of these spikes, and then there is no, what do you call it, QRS after them, that's a problem because that means the pacemaker's not working. Or if I have pacemaker spikes all over the place and it's not in the right place, that means it's not sensing my natural rhythm. And it can actually, remember we talked about, in another PowerPoint about PVCs. Like if I have a device that's telling my heart to beat at times it's supposed to be resting, then I can have like a lot of problems. I can end up going into abnormal rhythms. And then other times if they have a pacemaker and their heart rate's really low and it's just not working, like it's not functioning, that's going to be a huge problem too. So when you get to complex, you start kind of getting more into those pacemakers and really starting to see the ways that they can fail, and how as the nurse kind of knowing that. Don't worry if you're in med-surg and you're like, oh my god, I don't remember talking about any of these rhythms. Don't worry. We don't really talk about them at this level, but it's important to know, like, before you freak out and saying, what are those pointy things on my patient's rhythm? That's their pacemaker. This is going to help over time, whether or temporarily or over time, keep their heart rate in the normal beat so they can get good cardiac output. So there's also defibrillation and cardioversion. So, like I mentioned in my other PowerPoint about these rhythms, we defibrillate rhythms that have electrical activity but no pulse. If I defibrillated a person with a pulse, that's just mean. That is a lot of energy. I could actually probably get them completely out into a abnormal rhythm or stop their heart if I defibrillated them when they still had a pulse, because that can be like I said, it's very uncomfortable. It's a lot of energy, and it also it's a lot of electricity, so it can completely throw them off. So the rhythms that defibrillate are going to be ventricular tachycardia and ventricular fibrillation. And when I say ventricular tachycardia, I'm talking about ventricular tachycardia with no pulse. There's also what's called cardioversion. And cardioversion we do for rhythms like atrial fibrillation or flutter, SVT, PSVT, and then ventricular tachycardia with a pulse. And so the difference with this is that with cardioversion, I do this for rhythms that have there's a pulse present, but chaotic electrical activity. Now I'm trying to get it back to normal. Maybe I tried medications and it didn't work. We always want to do the least invasive first. So, usually I'm going to always start with, trying to do some, like when we talked about like SVT, I want to try the vagal maneuver first and then drugs. Most rhythms, we want to start with drugs first if possible. But if this patient's really unstable, we're going to go right to this cardioversion because we want to make sure that we can get them back to getting good, adequate cardiac output. But anyway, so defibrillation, it's for no pulse, but electrical activity. Cardioversion, pulse with chaotic electrical activity. Or, again, something where they're not getting good cardiac output. So what's really the difference here? So with cardioversion, this is something that usually like people can come in on like, and have it scheduled like, hey, I need to be cardioverted. But most of the time when the cardioversion that I'm used to in a critical care area, it's usually like, oh my goodness, they're in this rhythm. We need to do this right now. So it can be done in the OR or, depending on your facility, it can be done at the bedside. Usually they have to consent for it. We're going to sedate them because this is a shock. And even though it's not as strong of a shock as others, it is still strong and uncomfortable. So kind of like with the pacemaker, it's painful. So we don't want to just sit there and shock them. So we're going to usually sedate them. And the thing is they have a pulse. So they have a P wave, or I should say that I don't know what rhythm they're in. They have some sort of rhythm or electrical activity going on. And remember, we don't want to piss off that toilet or that T wave or that rest period. So what I have to do with cardioversion is I have to sync with their whatever rhythm they have. I have to synchronize my machine to that so that when it shocks, it's not shocking during that rest period or that filling time. Because remember what I said, if you shock or try to have a heartbeat happen in the middle of that resting period, it can throw the whole system off and their heart can completely stop. So we use lower energy, about 500 to 200, 550 to 200 joules, and we're going to monitor closely. And sometimes we have to do it a few times for it to work. Then on the other hand, there's defibrillation. So this patient, they are not awake. They have no pulse, VFib, VTAC without a pulse. There's zero cardiac output. We use a lot more higher energy. The client is unconscious, and we're going to usually be doing that ACLS protocol as well. So, what's my role as the nurse as a whole for dysrhythmias? I need to assess this patient. I'm going to be looking for signs for altered perfusion because it all comes down to cardiac output and getting blood out to my body to supply it with everything that it needs. I'm going to be checking their vital signs frequently and looking, checking their blood pressure, their heart rate, their respiratory rate, their oxygenation. And I'm also there to determine stability. How are they tolerating the rhythm? Because a lot of times, again, some people can be in a heart rhythm and not really tolerate it. Some people can be tolerating it better. So every patient's a little different. Keep in mind, some rhythms, even if they're like, "Oh, I'm fine, I'm good," it doesn't really matter. We still usually have to treat it, but I want to see how stable they are because that's really going to help guide me to when I'm calling the doctor and telling them, "Hey, this patient's in this rhythm. Here's what they look like." Like they need to know, like, what's the seriousness, what's going to be the best first option for the doctor to order, to treat this patient. Um, and if depending on the situation, especially if it's a situation like VTAC without a pulse or VFib, I'm going to or asystole, I'm going to use ACLS protocol, start CPR, unless I am already attached to those defibrillatory or the defibrillator and have the pads already attached. Then I'm for VFib and VTAC without a pulse, I'm going to fibrillate, first. Remember, asystole, you cannot shock asystole. So, sometimes, rather than, sit there and do in-depth assessments or be calling the physician, I'm going to be taking action. And if you're not unsure, like, all those situations, go back and watch my rhythms PowerPoint, the atrial and the ventricular, and they kind of tell you more step by step what actions to take there. As a whole, I want to support the patient's airway breathing circulation. I'm going to contact the physician to get my orders, and I'm going to monitor for effectiveness of medications. I also need to monitor for complications. Patients can, especially those in AFib and AFlutter, they can get blood clots. Every patient with dysrhythmias usually has some sort of hypotension. We're always going to be worried about that low blood pressure, lack of perfusion, and then I'm going to be looking for signs of decreased perfusion to organs, really making sure that seeing how this dysrhythmia is affecting them as a whole. And I want to protect for the patient's safety. Most patients with dysrhythmias feel kind of dizzy, lightheaded, don't feel good, their heart is racing. So I want to protect their safety. And if they have to get up and get out of bed, I need to make sure I'm with them and that the environment is clear and that they are safe getting to where they're going. So, one other thing to consider is what is my role in a code situation? So a nurse can do many roles in a code situation. When I first started out as a nurse, I always wanted to do compressions because I was like, okay, well, I can't really mess this up. And I mean, that's not true, but it's like it was a lot more mechanical and less of like a thinking process. And I didn't trust my mind back then. So I was like, okay, I'm gonna start with compressions. So one person is doing compressions, and usually techs will come in and help with this. Respiratory therapists will switch out. People will come to help. Other nurses can come and switch out as well. They should switch out when they're fatigued or at least every 2 minutes. And every 2 minutes, we do a pulse check and see what's going on with the patient. Another nurse can give medications, and we talked about, what medications are given during a code, things like epinephrine, amiodarone, calcium channel blockers. We can give electrolytes, we can give sodium bicarb, all that stuff. And again, you don't have to know all of those in depth, but just being familiar with some of those would be helpful to kind of know what should I expect to be giving? How is it going to help the patient? Now today, as when I go into the what do you call it, codes, I don't really like to be a part of the action anymore. I used to want to be in there and be like, okay, yeah, how can I help? So I like to stand in the corner now and be the recorder, which means I'm there and I'm watching what everyone's doing and I'm keeping track of everything. I'm going to tell them, hey, it's been 2 minutes. We need to switch compressors. Hey, it's been 2 minutes. You can give more medication. And I'm going to just be like really verbalizing everything that's going on, and I'm going to chart it in the computer for that nurse, whoever's patient it is. And so I'm going to be pretty much writing down and charting everything that's happening as it's happening. And they have these really cool things in our charting system where we can record all of this really easily, and we can click boxes and be like, okay, we're still doing CPR. Okay, we gave this med. Okay, we did this, and kind of go through. Um, and if no doctor's present, the nurse can also be in charge, make sure everything's running smoothly and all team members are communicating and kind of starting to talk through, okay, well, what might be the possible cause? What are some other options we can do for this patient and stuff like that? So yeah, so there's a lot of different roles, and as you become a nurse and a fabulous nurse, you're going to become, you'll get to kind of see, what role that you fall into. Just make sure you're helping and not just sitting in the corner and crying. All right, so that is treatment of dysrhythmias, just a little basic overview. Hopefully, it was helpful, and more to come. See you later.